My name's Matthew Rees. I work at the Mayo Clinic, and today I'll be talking about a class comparison of BCMA-directed therapies in relapsed multiple myeloma. Currently, there are three classes of BCMA-directed therapy available for relapsed myeloma: CAR T-cells, T-cell engagers, and antibody drug conjugates. Each class has distinct strengths and weaknesses, and while we have no head-to-head comparisons of these drugs, there's consistent evidence that the efficacy of the BCMA-directed therapies is reduced in patients who've had previous exposure to a BCMA-directed therapy compared to those who have not. We undertook this research to compare the features associated with treatment failure between the three classes of BCMA-directed treatments. It was a single institution review. We looked at all patients treated at the Mayo Clinic between 2018 2023. Patients who had received more than one BCMA-directed therapy over the time period were eligible to contribute data for each class received. We had a total of 339 individuals. The majority received just one treatment. About 40 patients received two BCMA-directed therapies, and a handful of patients received three. In total, 385 BCMA-directed therapies were received. We had a median follow-up time of 21 months, which was slightly shorter in the CAR T recipients. Approximately half of the patients received their treatment as part of a clinical trial, and a total of 59 individuals had a history of prior BCMA-directed therapy exposure. Baseline patient and disease characteristics are shown in the table on the right. Patients who received antibody drug conjugates tended to be older, have a poorer performance status, more previous lines of therapy, and more penta-refractory disease. The reverse was typically true of patients who received CAR T therapy. Furthermore, more patients who received antibody drug conjugates or T-cell engagers had a history of prior BCMA exposure. Looking at the response rates, we saw that CAR T therapy produced superior response rates overall and amongst patients with prior BCMA exposure, extramedullary disease or plasma cell leukemia, and patients with penta-refractory disease. Patients who had extramedullary disease and received antibody drug conjugates had a poor overall response rate of just 12%, which was similar to the results of the DREAM. We also saw that CAR T had the largest fall in response rates for those individuals with prior exposure, falling from 86% to 50%. With regards to survival outcomes, we saw that CAR T produced superior overall survival and progression-free survival compared to the other classes. Furthermore, this remained significant on multivariable analysis adjusted for age, extramedullary disease, double-hit high-risk cytogenetics, previous BCMA-directed therapy exposure, and the number of lines of therapy received in the preceding 1 year. We also observed that T-cell engagers produce superior overall and progression-free survival compared to antibody drug conjugates. And again, this was significant on multivariable analysis. Looking at high-risk subgroups, we saw that for people with penta-refractory disease or double-hit high-risk cytogenetics, there were improved outcomes with CAR T compared to the other classes. However, amongst patients with extramedullary disease or plasma cell leukemia, all classes had poor median progression-free survival, with the longest median progression-free survival seen in CAR T recipients, but only being 6 months. Amongst patients with previous BCMA-directed therapy exposure, there was no significant difference in outcome, and survival with all classes was poor. We also examined the real-world use of teclistamab at our institution. We had a total of 41 individuals who received this drug. Half of those individuals had extramedullary disease at the time of treatment, and the majority had received a previous BCMA-directed therapy prior to treatment. A median follow-up of 9 months, median progression-free survival was 3.3 months. The median duration of response was not reached. However, when we examined just patients who were BCMA therapy naive, the 12-month progression-free survival was estimated at 56%. Lastly, we examined the mode of relapse for patients who were treated with BCMA-directed therapy. We had a total of 234 cases of relapse. Cross-sectional imaging and lab tests were available in 201 cases. Of these, approximately half had extramedullary disease or plasma leukemia present, and 25% of these individuals had no prior history of either. The rate of acquired EMD or plasma cell leukemia was similar between the three classes. The limitations to this research, it's a single institution review and subject to all the limitations inherent to research of that kind. There was obviously significant bias in the application and selection of these therapies, and that was reflected in the baseline patient and disease characteristics and undoubtedly would contribute to the survival outcomes we observed. We analyzed CAR-T patients on a per protocol analysis. Such that patients who were planned for CAR-T but who never received CAR-T therapy were excluded, and this would have augmented the survival and response outcomes seen for this group. Lastly, a moderate proportion of patients received investigational products which do not have established efficacy, and the mode of treatment for both antibody drug conjugates and T-cell engagers in this study was generally monotherapy, and that is subject to change with further research as we see them increasingly used in combination. So in conclusion, we found that BCMA-directed CAR-T produced superior response rates and survival compared to the other forms of BCMA-directed therapy. Extramedullary disease was difficult to treat with all classes and was a common mode of relapse. We saw that BCMA-directed therapy adversely impacted all the classes, but it had the greatest detrimental impact on CAR-T. And in our real-world experience with teclistamab, where we had a high proportion of patients with extramedullary disease and previous BCMA exposure, our response rates were lower, as was our progression-free survival compared to what was seen in the registration trial of Majestic-1. However, if we restricted our analysis to BCMA-naive individuals, outcomes were similar. These are my references. I'd like to acknowledge the patients and their families, the co-authors, especially Dr. Kumar, my mentor, HSANZ, and the Snowdon Foundation. Thank you.